Net connectivity was not there. Okay. Yeah. Yeah. So as we were discussing, in a patient who is having paroxysmal nocturnal dyspnea, if that patient develops right ventricular failure, what will happen to his paroxysmal nocturnal dyspnea? Will it get aggravated or will it disappear? Will PND disappear or PND aggravates after once right ventricular failure sets in? Excellent. Ishan energitis, it should become less. But the failure status or progression of the disease is going more and more. Okay, this you should remember. So PND, if it is settling from previously, then that means right ventricular failure is setting in mitral stenosis. Okay. Yes. So this we'll understand if we discuss further. Okay. Next is small discussion on orthopnea. So orthopnea, what will happen? In PND, it was 2 to 3 hours after going to sleep. What about orthopnea? Good, Bovika, Ishan and Ninja, come on. In orthopnea, after how many hours the patient will develop shortness of breath? Yes, Sai Subramaniam, excellent. It is immediately. So what happens here is all the blood from the pedial edema and all kind of extra interstitial blood fluid will enter into the circulation and will enter into the right heart, leading to right ventricular volume overload. So what will happen? See, from the right ventricle, lot of blood is going to the lungs. At the same time, from the lungs, blood can't come to the right left atrium because of elevated pressure. So blood gets pooled in the pulmonary circulation and pulmonary edema develops instantaneously in case of orthopnea. Okay, so if orthopnea is there, we can grade it as severity NYHA class 4. Okay, these two things you should remember. Next, we will see what happens in MS, how MS progresses and how it produces features. Okay, yes. So first answer this. See this is the left atrium, this is the left ventricle, and this is the aorta. So what happens in mitral stenosis? If you see closely, there are two cusps, and what is this? And papillary muscle connected to the ventricle, myocardium of the ventricle. This is papillary muscle. This is cusp. What about this? Connecting the cusp to the papillary muscle. This is nothing but caudate tendinae. So if you see in mitral stenosis, what happens is, in this valve, fusion starts to happen from the commissures. Okay, these are the edges of the valves or cusp are called commissures. So this starts to fuse, resulting in mitral stenosis. So this is known as commissural fusion. Okay, why do we need to do this? Because pathology starts here only. Okay, so what happens next is, since this mitral valve is completely stenosed, left atrium needs to put a large amount of pressure to pump whole blood into the left ventricle. So what happens in course? What happens to the left ventricle? Slowly, left atrium slowly. Left atrium starts to undergo hypertrophy. Okay, and also if you see, Left atrium, if it undergoes hypertrophy, what happens to the LA size? Left atrial size, actually normal left atrial size is 4 centimeters square. Okay, if left atrial size increases even to 4.1, what will start to happen? What symptom will start? Left atrial dilatation will cause what symptom? See this? Left atrium is getting dilated, leading to what might happen? Blood starts to pool here. Stasis happens. Stasis is one of the component of Virchow's triad, which says that blood will starts to form thrombus. Thrombus formation starts. Excellent. Lesion and anxiety, atrial fibrillation, palpitations. Okay. The left atrium starts to dilate. Even zero point 0.1 centimeter dilatations will cause atrial fibrillation. Okay. Atrial fibrillation we will see in detail. Don't worry. Atrial fibrillation, and this will cause palpitations. Then what starts to happen? Since dilated left atrium, stasis of blood happens, blood clots, blood starts to form thrombus. This thrombus can, what can this thrombus do? This thrombus can block this orifice, leading to sudden onset of shortness of breath in MS. MS, if you see, it is a chronic disease. See, dilatation of left atrium happens, the pressure increases, and the back pressure increases in the pulmonary circulation. And what happens here? Fluid starts to exude into the alveolar spaces, leading to alveolar edema and chronic accumulation of fluid there. It might rupture some of the alveolar capillaries due to this increased pressure. So alveolar capillary rupture will cause what symptom? Hemoptysis. And due to chronic elevation of pressure in the pulmonary veins, what will happen is fluids not only starts to exude in the alveoli but also along the walls of the bronchiole, leading to bronchiolar edema, and this we call it as winter bronchitis, because the patient starts to develop cough with expectoration in winter, and this also happens here. So hemoptysis might happen, winter bronchitis happens. Okay. Then what happens to this pulmonary vasculature? See this here. Yes. See what happens here? Pressure increases. So what? This is the pulmonary vein. Okay. Due to elevated pressure, what happens is this vein becomes thick and thick, leading to arterialization of vein. Arterialization meaning to withstand the elevated pressure, this pulmonary vein becomes arterialized, okay, fibrosed, thickened. So thickened meaning what will happen? This blood will directly, this pressure will be directly transmitted to pulmonary artery. So if this happens, what will happen here with respect to right heart? So the right heart now, what it will do as a preventive mechanism for pulmonary edema. So, as we know, fluid is transmitting out into the alveoli. So, right heart should do some protective mechanisms to stop this pulmonary edema. Can someone say what does the right heart does? What does happens to the pulmonary artery to prevent the pulmonary edema? Can someone say this? Excellent. More resistance in pulmonary arterial artery hypertension. See here. So this is a small diagram to represent this. See, blood is coming, lot of blood is coming to the lungs. At the same time, blood can't leave the lungs to the atrium because of the elevated pressure in the atrium. So blood starts to pool in the pulmonary circulation. So to prevent some more occurrence of edema, what happens, what a protective mechanism happens is pulmonary artery undergoes reactive vasoconstriction. Why vasoconstriction? To prevent the flow of blood to the pulmonary circulation so that pulmonary edema doesn't happen. So what this will cause? This will result in pulmonary artery hypertension. Okay, excellent. Ishan and Aja, it is pulmonary artery hypertension. Good. So, see this. Pulmonary artery hypertension, BP hypertension is going on here. So, what happens to the right ventricle? To overcome this pulmonary hypertension, what will the right ventricle do? What is there happening in the right ventricle? Can someone say this? What is happening in the right ventricle? Excellent. Right ventricle is undergoing hypertrophy. Okay. This right ventricle will manage to, excellent, Bhavika, Ishan and Aja, pressure overload getting hypertrophy. Excellent. So, right ventricle, what it does is, at one point of time, this hypertrophied ventricle will fail. So, right ventricle will eventually undergo dilatation. Okay, see this. Right ventricle undergoes dilatation. So, what will happen? The leaflets were previously closing properly because of this normal size. Now what is happening? Leaflets are pushed away, pulled apart. Okay, so what valvular lesions is possible in this right ventricular failure? Right ventricular dilatation? What this will cause and what this will cause? Excellent. It is tricuspid regurgitation might happen. At the same time, here what can happen? Blood pumped into the pulmonary artery coming back. Excellent. PR. Good. Bhuvika. It is tricuspid regurgitation as well as pulmonary regurgitation is possible in MS. You should remember this also, because you should not focus only on auscultation of that apical area and finding the diastolic murmur. You should also keep in mind that TR is possible, pulmonary regurgitation is possible, right ventricular hypertrophy is happening, pulmonary hypertension is also happening. All these you should remember. Okay. Yes. So now we will come to our discussion. So see here, I have framed a history for in all 4 valvular heart diseases. How it will be. Okay. It's your turn to guess what all can happen. Shortness of breath history. Okay. In mitral stenosis. Acute in mitral stenosis, shortness of breath will be acute onset or gradual onset normally. Start guessing. Is it normally gradual or insidious onset in mitral stenosis, or is it acute onset? Excellent. Gradual. Okay. My question now is, what if shortness of breath happens acutely in mitral stenosis? What are the possible causes? See, we were discussing here shortness of breath happening here. Yes, if some thrombus has formed in the left atrium and if this thrombus suddenly goes and blocks the aperture of the mitral valve, then back pressure will increase excessively, leading to sudden onset of shortness of breath in MS. At the same time, if MS patient starts developing what is this arrhythmia? Atrial fibrillation, then also atrium is not contracting, back pressure starts to elevate, patient starts to develop pulmonary edema. So these are two conditions you should remember. Even sudden onset shortness of breath is possible in MS. Okay, one is thrombus, one is atrial fibrillation. Okay, next step. What about MS? Like, see this shortness of breath is exaggerated with climbing stairs, exertion. Okay. Next, it is relieved by taking rest. Okay. Then, this thing I was saying. Then it is like orthopnea PND is like if it is there, then it indicates failure. What failure? LV or RV failure. Orthopnea PND. It is always left-sided failure. Okay. Yes. Next is mitral regurgitation. So in mitral regurgitation, how will be the shortness of breath or something like palpitations? Usually in mitral regurgitation, how it will be? See, first you should know when mitral regurgitation happens. See, whenever this papillary muscle I was saying, which was holding the cusp, if this ruptures due to some phenomenon, this mitral valve can't close back, leading to regurgitation. So, what are the causes? If you want me to enlist, You should know three main causes. One is infarction (MI) causing rupture of papillary muscle. Next is infection, infective endocarditis causing rupture of papillary muscle. Okay. Next is acute rheumatic fever. Acute rheumatic fever will have that valvulitis, they will say, and this MR might manifest. Excellent. Buvika, it is acute MR. Excellent. Three causes. So mostly in these three causes, it will be acute onset shortness of breath. Then same thing for everything. Like in MR, is it a volume overload state or a pressure overload state? So what a overload state it is? It is a volume overload state. So the patients will typically say if they take diuretic, they feel a lot better. Okay, this thing. Next is excellent. Sai Subramaniam, it is volume overload. Bhuvika. So orthopnea in the same thing. If it is there, then it is left-sided failure. Okay. So this I have listed about mitral regurgitation. Next, aortic stenosis. So how will be the classical symptomatology in aortic stenosis? See, mostly if you see, it will be some acute onset only. Okay, some it is like duration. Onset के अलावा we should discuss like duration. If you see duration of disease, aortic stenosis will usually be less than 5 years. Okay, what's it plus or minus in MR? Orthopnea and PND might be there or not. Like if it is present, then it indicates left-sided failure. If it is absent, then it indicates that left-sided failure hasn't happened abhi tak. No. Okay. Next is aortic stenosis. Duration, if you see, it will be less than 5 years. And why it is less than 5 years? Because see here, what happens in aortic stenosis is this valve is completely stenosed. All the blood from the left ventricle should be pumped through this narrow valve. Left ventricle undergoes massive hypertrophy. It's a pressure overload state. Okay, pressure overload state. So this will cause acute exacerbation of symptoms. Okay, then it is definitely aggravated by exertion. Can someone say the classical triad of aortic stenosis? Exertion induced, shortness of breath, exertion induced, angina, exertion induced syncope. This is the classical triad with respect to aortic stenosis. Excellent, Sai Subramanian. So then what happens? Aggravated by exertion, relieved by taking rest, or the PND. If it is there, then it's failure. If it's not there, then it's normal. Okay. What about aortic regurgitation? Same thing, same acute process for aortic regurgitation. What all you can expect? This infective endocarditis eroding the valve, leading to aortic regurgitation, and you should know this some immune-mediated cause also, like ankylosing spondylitis. Okay, all those immune-mediated causes are there. At the same time, important cause, one more important cause is rheumatic fever always exists. Here also rheumatic fever exists. Rheumatic fever in everything. Okay. Yeah, infected endocarditis, immune-mediated mechanisms. Then Marfan syndromes, Marfan, Ehlers-Danlos, all those connective tissue disorders. Okay. And one more thing, most important thing you should remember with respect to valvular heart disease. My question is, can systemic hypertension result in aortic regurgitation? Yes or no? Try answering this. Can systemic hypertension result in aortic regurgitation? Yes or no? Remaining to subnormal. See, same thing only. On exertion, relieved by diuretics, since it is a volume overload state. Orthopnea PND, if it is there, then it's failure. Yes. Why? Ishan and Anisa, can you explain why systemic hypertension can result in AR? What is the reason behind it? Aneurysm caused by hypertension, then it can cause AR. Okay. Okay. But just think, normally, what happens in hypertension? This pressure is excessive. So to combat excessive pressure, what will happen to the left ventricle? It undergoes pressure overload and LVH starts to happen. Left ventricle hypertrophy starts to happen. At one point of time, left ventricle, what will happen to the left ventricle? This hypertrophied ventricle will be at one point of time it will be dilated. Okay. So at that point of time, these valves were closing normally previously. Okay. Now what happens? These valves can't close properly. Okay. Now it results in what is happening here? Aortic regurgitation. So you should remember that systemic hypertension is one of the important cause for AR. Got it? Just give me a thumbs up smiley if you have got this. And see, this is the normal history with respect to this 4 heart diseases. Okay. Regurgitation, mitral regurgitation. First symptom will be palpitation. Aortic stenosis, first symptom will be exertion induced, all this triad will be there. Okay, mostly aortic stenosis, exertion induced chest pain you should remember. And here aortic regurgitation also, first symptom will be palpitation. All volume overload conditions will cause palpitations as the initial finding. And MS will cause shortness of breath as well as palpitations. Some books tell you first symptom as palpitation, some books tell you first symptom as shortness of breath. Okay, so you can remember like this. Yes. Next, we will go and deal with our symptomatology. So it's done with our symptomatology. Now we'll deal with the history for some time. So now you study gradual insidious onset, which is more towards MS, gradually progressive. Initially, it was present during climbing stairs, working more than 12 hours per day, which is severe exertion. Now it is present even on bathing, brushing, cooking, which is NVHA class 3. Next, what happens? Next, waking up in the night, shortness of breath after 2 to 3 hours, I have told, going to sleep since last 3-4 months. Then on relieved on sitting up, standing, going near window for getting fresh air. See, on sitting and standing, what happened? Why PND relieved on sitting and standing? Because on standing, sitting up, what happened? Then we were seeing our seasonal variation. The seasonal variation also helps to rule out asthma. Okay. Yes. No strabotopnia, easy fatigability, we are saying yes. What does this easy fatigability indicate? Very important sign with respect to mitral stenosis. First question is this. Why PND reduced or relieved after sitting up or standing? Start answering. Why PND relieved? Excellent. Venous pooling. Okay. So what happens is on standing and sitting, what happens is the blood starts to pool in the low venous return. Venous return is reduced, so low cardiac output. So decreased blood to the coronary circulation, decreased pulmonary edema. Excellent. Viva plus each and another. Next, we are seeing this thing. Why easy fatigability was seen? What is the reason? Next, we are discussing of palpitations. We are discussing insidious onset, progressive in nature. All indicates some gradual phenomenon happening in the patient. For 10 years, it is there. And on exertion and rest relieved, all are characteristic of CVS. So it's sweating, definitely. Sai Subramaniam, anemia due to hemoptysis. Okay, good thinking. Then first, I want to ask you people, how will be the cardiac output in mitral stenosis? Will it be elevated? Will it be normal? Or will it be low? Answer this. How will be the cardiac output in mitral stenosis? Excellent. It will be reduced because blood from the left atrium is not at all coming to the left ventricle. Okay, so definitely cardiac output will be reduced. So reduced cardiac output, low blood circulating, supplying the muscles, supplying the all over the body will definitely cause fatigue on limited activity. So this is an important symptom which represents low output, low cardiac output. This is sign of low cardiac output. At the same time, what and all signs of low cardiac output? One is fatigue. Next, what more can happen? If low blood is supplied to the kidney, what will that show? And low blood supplied to the kidney, it will cause reduced GFR, reduced renal blood flow, and that will lead to oliguria. Okay, this is also a symptom of forward failure. Sorry, low cardiac output symptom. Excellent, Ishan. So all these symptoms will cause, okay, oliguria, fatigue, all these symptoms are there. Then what and all might be there? See, then what and all happen? What might happen is reduced cardiac output to respiratory muscles also can cause shortness of breath. Okay. Yes. Next, reduced cardiac output to the myocardium is the cause for anginal pain on exertion. Exert, the oxygen requirement increases, and since it is low cardiac output, it can't match, then anginal pain can happen. Okay. Next, history of coughs we are seeing. Repeated attacks in past 1 year. Productive sputum was pink frothy. Now I want to know why it is frothy sputum. What is the reason behind pink frothy sputum? Blood tingled in some episodes. Just 5 to 10 ml. Can someone say why it is frothy? Sputum is frothy. What does that indicate? Excellent. Pulmonary edema mixed with blood. Okay. Actually, why it is frothy is, see, pulmonary edema is there, as you told. Fluid mixed with what is there in the alveoli usually? Air. So, water, when it is mixed with air, what happens? Yes, it turns about to be frothy. And blood is also there, so it turns the color to pink color. Excellent, Bhuvika. It is air, blood, and edema. So, it is pink, frothy sputum. Okay. Yes. Then hemoptysis might be there due to some rupture of some alveolar capillaries. At the same time, one more question I wanted to ask. Can hemoptysis happen in some other cause due to in MS? If the MS patient is chronically taking some drug, can it cause hemoptysis? Let's see who answers this. No idea. Excellent, Bhuvika. It is warfarin. Because these patients will be on chronic use of anticoagulants. Because if these patients develop atrial fibrillation and if they have some left atrial clots formation, we should inhibit the clot formation. So we will be giving those patients anticoagulants. So if you just overtreat the, if they take excess of warfarin, or if they fail to check what you should monitor, if the patient is on warfarin, if the patient fails to monitor this test, then also the patient might develop hemoptysis. Okay. Monitoring of what test? When we use warfarin, what should be monitored? Okay, I'll say that. It is PTINR. Excellent. Aishan and Aishwarya Verma, it is PTINR should be monitored weekly. Okay, first when we start a warfarin, we should be giving warfarin to achieve the control target PTINR. Okay, if they don't achieve the target PTINR, if they are excessively going above PTINR, then it might result in hemoptysis. Okay, next. Next, we are seeing no history of chest pain, loss of consciousness. See, no history of pedal edema, abdominal distension, nausea, vomiting, loss of weight, loss of appetite. All these are symptoms of what? And no history of decreased urine output, hematuria, fever, joint pain, lesions on palms and fingertips. All these are suggestive of what? No history of paralysis, speech defects in the past, baggage discoloration of symptoms. All these are suggestive of what? And this symptom is suggestive of what? Start guessing. Why am I including all these things? What is the first subdivision success to of? Fetal edema, abdominal distension, nausea, vomiting, loss of appetite, loss of weight. You can add also distended neck pulsations. Excellent. Bhuvika, it is right-sided failure, right heart failure. Okay. This can decrease urine output, hematuria, fever, joint pain, lesions on palms and soles. This might relate with suggestive of infective endocarditis. Okay. Next, this is suggestive of paralysis of limbs, speech defects, or suggestive of embolic phenomenon. Excellent, Bhuvika. It is Ortner syndrome for hoarseness. Excellent, excellent answer. Hoarseness of voice and difficulty in swallowing is due to compression symptoms. Like what will happen is this enlarged left atrium will start to compress the esophagus and recurrent laryngeal nerve, resulting in difficulty in swallowing and hoarseness of voice. If hoarseness of voice happens due to enlarged left atrium in MS due to compression of RLN, we call that syndrome as Ortner syndrome. Okay, yes. So this is what you should ask in history of mitral stenosis. Okay, should ask for the SARS-2 of right heart failure, SARS-2 of infected endocarditis, embolic phenomenon, compression symptoms, and any blood loss is there or not. Everyone got it? If you got it, just put a thumbs up smiley. I'll be proceeding to next thing. Yeah, see here. This is the S. So see here, this is the right heart failing here, leading to back pressure accumulated. If it is back excessive neck में JVP will get distended, and you can see that. And if back pressure is elevated, it can cause hepatomegaly, splenomegaly. Okay, then congestion in the GIT. See, from GIT, blood can't move into the portal circulation. Blood starts to get stagnant in the GIT here itself. So nutrients and glucose, all those proteins can't absorb properly. So decreased absorption goes on in GAT. So what happens? The patient's weight reduces, appetite reduces, and the patient will get cachexic, loss of weight. This we call it as cardiac cachexia. Okay, so don't just think for any patient, like if they don't have appetite or if they are having loss of weight, just you can think of this cause also, right heart getting failed. At the same time, if you see properly, this thing will be happening. Pedal edema will be there. Okay, these are all the symptoms of right heart failure. Okay. Yes. Next, I was speaking of those symptoms as to of embolic phenomena. So see here. See here. What happens here? The left atrium getting dilated, blood starts to pool, and blood clots start to form, and this clot is showered like anything, which is known as embolic shower. We will say it's starting to shower everywhere, and if it goes to the coronary circulation, that might result in CVA. Okay, hemiplegia might happen. Yeah, nausea, vomiting in RSF is also due to this congestion only. Congestion of blood stagnating there itself. Nothing can be absorbed. Blood, food start to stagnate, so it starts to regurgitate and come out. Then if you see emboli shower going, it can go to coronary circulation. See, this emboli can embolize to cerebral circulation resulting CVA, heart resulting in MI, or this can embolize to GIT, mesenteric artery leading to mesenteric ischemia, where the patient will have severe pain after eating. Next, the thrombus can also embolize to some muscular artery. See here, some muscular artery that will cause what? Darkening, or this is the gangrene, blackish discoloration of fingers. Okay, all these history we should ask for to rule out the embolic phenomenons. Got it? Just put up thumbs up smiley. Let me move forward. Or should I show some slides? Okay. Then we were seeing the past history where the patient was having all these symptoms, but around 12 years he developed multiple joint pains, for which some 10 to 12 tablets was given. What is this tablet? These joint pains will be controlled only with this tablet. What is this? High dose aspirin. Okay. Yes. Then history of fever was there. Yeah, family history, cardiac related disease. You can just ask for family में what and all diseases can happen. One is this MI, coronary artery disease, can be familial, or cardiomyopathies can be familial. Sudden onset cardiac arrest can be seen in hypertrophic obstructive cardiomyopathies. All these, excellent Sai Subramaniam, it is aspirin. Okay. Next, yes, treatment history. Yeah, you can ask treatment, what all medications he's on. You can ask that. And what about these monthly injections? Nothing but the secondary prophylaxis. Okay. According to in India, if the patient has rheumatic heart disease, then the prophylaxis is lifelong. Never ever forget this. Prophylaxis should be lifelong for the patient, because in India it is incidence is so much. Okay. Yes. So with this history, I say that cardiovascular system is involved. Side affected is left side. And what valve is affected? Mostly mitral side is affected. Because for if it is aortic, then what all I would have had, and someone say what all will be there if aortic valve is affected. First is duration. Okay, duration will be, it will be less than 5 years, but here it is more than 5 years. And mostly palpitations are less common in aortic stenosis. No. Okay, this thing you should remember. Yeah, next we will see the examination part. So yes, the patient was examined in well-lit room. The patient was sitting on bed. Patient is averagely built. Weight was this much. BMI is normal. Pallor was present, but no history of any clubbing cyanosis, lymphadenopathy, edema. BP in right upper limb, left upper limb, all four upper limbs you should, all four limbs you should measure BP. Okay. Next important thing, which is the pulse in mitral stenosis. See, pulse you should count the heart rate, pulse rate, how much is there. Then you should tell the rhythm of the pulse, whether it's regular, or is it irregularly irregular, or is it regularly irregular. You should tell this rhythm. Most important in MS. Okay. Next, volume is normal volume. See, volume, how are you going to measure volume? Just calculate the pulse pressure. Okay, pulse pressure is systolic blood pressure minus diastolic blood pressure. So if you measure this, it comes to be 40, 100 minus 60. So if it is in between 30 to 60 means it is normal. If it is less means it is narrow pulse pressure. If it is more means it is wide pulse pressure or high volume pulse. So volume of a pulse is determined by pulse pressure, not by palpating. You are feeling normal volume easily. Okay, so it is palpated by, sorry, it is felt by pulse pressure. Next is any special character, no special character. All peripheral pulses are felt. Why is this important? Why all peripheral pulses must be felt in MS? Next, no radio femoral delay, no radial delay. No vessel was delayed. Pulse deficit was calculated. It was found to be 15. Okay. What does this signify? I want answers for all these three. Why you should measure BP in all four limbs? First, why you should palpate all the peripheral pulses? Next, why? What is the importance of pulse deficit? 15. Excellent. Ishan meningitis. Pulse deficit of more than 10 indicates atrial fibrillation. Pulse deficit means difference between heart pulse rate and heart rate. So one will be oscillating the patient and one will be palpating the pulse and they will count the pulse rate and heart rate. If the difference is more than 10, then that means atrial fibrillation is going on. Excellent. Sai Subramanian, Nishan. Okay. Why should palpate all the peripheral pulses? Can pulse be absent in any peripheral pulse? Is it possible in MS? Can some phenomenon cause absent pulse? ABPA measurement for BP. Oh no, that is not needed. Only if you find like any abnormalities there with respect to BP, then you can go for good ankle brachial pressure index and all. So why it is there is excellent. Bhuvika, it is embolism. So all embolism might happen. If embolism happen to one of the peripheral blood vessels, then their pulse won't be there. Okay. At the same time, BP you should measure because of this only. If embolism is there, then they in that part of the limb BP won't be normal. It will be very reduced because it can't record the BP itself. First of all. Okay. Yes. The next respiratory rate JEP not raised. Okay. Hepatojugular reflex absent. So if hepatojugular, what is hepatojugular reflex? And if it is present, what does that indicate? If it is present, what does it indicate? Hepatojugular reflex. Excellent. RHF. See, you should say it as impending RHF. Like right heart failure is not visible till now, but by doing this reflex, you can find if it is about to come or not. It doesn't indicate right heart failure, but if it is there, then it indicates right heart failure is about to come. Okay, so how to do that hepatojugular reflex? See here. Yes, JVP. How to do it is you should palpate the umbilical region of the patient. Okay. You should palpate the umbilical region of the patient for some seconds and then you should see whether JVP elevates or not. Okay. You shouldn't press the hypochondrium because in right heart failure patients, hepatomegaly, that will be congestive hepatomegaly. So the patient will already have pain. You can't press there. Just press the umbilical region of the patient for some 1-2 minutes. You will find the JVP elevated. Okay, if it is there, then it indicates impending right heart failure. Okay, yes. Next, Head to examination. No malar flush or malar rash. Malar rash is seen in, malar flush is seen in water. Next, no loss of scalp hair, no thyroid swelling. We should see for thyroid swelling because hyperthyroidism can also cause atrial fibrillation. Okay, that you should rule out whether it's there or not. Excellent. Ishan meningitis, excellent Aishwarya-itis, SLE. Malar flush is seen in mitral stenosis. I was telling na, that mitral stenosis is a low cardiac output state. So what will happen? Decreased blood flow and it will cause peripheral cyanosis. Okay. And also there will be peripheral vasodilations be also will happen. All this will cause a malar flush in MS. Excellent. Bubicitis, Liebman Sachs endocarditis if it happens in SLE. So SLE can also cause MS. Na? So we want to see whether malar rash is there or not. So scalp hair loss, all these will indicate hypothyroidism. Whether it is there or not. Hyperthyroidism is there or not. Okay. Next, arachnodactyly. What does arachnodactyly indicate? And if syndactyly, why are we seeing it? Because to rule out any congenital heart disease. Okay. But this patient has loss of malar flush in MS. No, it is not like it is not. It is a must present in all case of MS. Okay, it might be there in some case of MS. Like if when the patient was examined, she was not having it. Yes, excellent. It is. Arachnodactyly is there in a connective tissue disorder known as Marfan syndrome. So we saw that Marfan syndrome patients are more in risk for aortic regurgitation, aortic aneurysms. Okay, so we should see arachnodactyly at the same time arm span you should see, and you should compare the upper segment and lower segment ratio. Okay, this should be normally less than 0.86. Okay, if it is greater than 0.86, then it is one of the criteria for Marfan syndrome. Okay, this you should remember. Next, you are seeing for any signs of infected endocarditis or active rheumatic fever. Okay, for this you can see for joint tenderness and any skin lesions like erythema marginatum. Okay, all these things you can see. And infected endocarditis, you will see skin lesions on the pulp of fingers, soles, and any hematuria is going or not. Okay, all these are signs of infective endocarditis. Okay. Next, we can go to examination. So in examination, what all we are seeing? Shape of the chest, which is normal. Trachea is in midline. No precordial bulge. Where does precordial bulge happens? Okay. Next, no scars and sinuses. No distended vessels. Parasternal and epigastric pulsations are seen. Okay. And apical impulses at fifth intercostal space 1 centimeter lateral to mid-clavicular line. Is it normal? And no ectopic pulsations are seen. Okay, we will see a quick overview. We'll finish it up and we'll see a quick overview of apical impulses. Okay. Palpation, inspectory findings. This you should remember. This is a must statement that should be written on palpation. Okay. All inspectory findings are confirmed on palpation. Next, apex beat. Sorry, it is felt at left fifth only. Apex beat is felt on left fifth intercostal space, 1 centimeter lateral to mid clavicular line. Character of apical impulse is tapping. Diastolic trill is present in the apical area. Parasternal heave is present, which is not obliterable. So what is this grade? Then palpable P2 is present in pulmonary area. Epigastric pulsations is felt at the tip of the finger. So what are these findings represent? Next, auscultation. Apex auscultated, loud S1 was there, opening snap was there, murmur, which was a low pitched mid diastolic rumbling murmur, high grade, grade 4, no radiation of murmur, murmur heard well with the bell of stethoscope, the patient lying in left lateral position during the act of expiration. Okay, no systolic pre-systolic accentuation could be heard, no S3, S4. Expiratory area S1, S2 plus no murmur, aortic area normal. But in pulmonary area, I can hear an ejection systolic murmur and loud S2. Okay, then respiratory system, minimal crepitations, end inspiratory crepitations were heard in the basal areas of both lung fields. Why? Then CNS and G8 is normal. Okay, so what does these findings represent? From first we will come. See how you should inspect, should go stand in the right side of the patient. Okay, then you start inspecting first, see the shape of the chest. How is this shape of the chest? Okay, is it barrel shaped like in COPD patients, or does he have any pectus excavatum, pectus cavinatum? Okay, pectus excavatum, cavinatum, like this. Chest deformities are there or not? Because these deformities itself will cause shifting of apical impulse left and right. Okay, so first you should rule out all these deformities of the chest. Then you are going to see trachea. Is it midline or is it shifted here and there? Next you are going to see the precordial bulge. When precordial bulge is seen, see, this is the chest rib. Heart is here. When pericardial effusion happens now, what happens is, see, this fluid will accumulate and it will cause a bulging in the intercostal space. Okay, if precordial bulge is there, then it indicates pericardial effusion. Okay, at the same time, if precordial bulge is there along with a bulging of the ribs also, when will that happen? See, precordial bulge is there in the intercostal space as well as ribs also bulged out. What does this mean? Meaning, ribs bulging out, meaning it has started in the childhood itself. During development of ribs itself, this right ventricle was that much hypertrophied, it was pushing the ribs with each pulse since the development, childhood development. So it has caused bulging of ribs as well as bulging of intercostal space. So this indicates RVH is there. Since right ventricle is more closer to the costochondral junctions, their development actually starts developing in the childhood. So at that stage itself, if RVH is happening, then it will cause bulging of the ribs as well as bulging of the intercostal space. So it indicates RVH is happening since childhood. Got it? If you got it, just put a thumbs up smiley. Okay. Yes. Did you get this? Okay. Next, parasternal as well as epigastric pulsations. Whether these pulsations are seen or not. So what does this indicate? Parasternal means to your instant left of the sternum, right ventricle is there. So if right ventricle hypertrophy happens, then the pulsations will be visible. At the same time, this will be visible in the epigastric region too. So epigastric region as well as left parasternal region, both are important locations to see for the RVH. Right ventricular hypertrophy is going on. Okay. Next, which is the normal position of apical impulse? Is this normal? Ishan and Aneja? See this. We will have a short clinical image based discussion. See this. This is how you should palpate for apical impulse. Okay. Take your right hand. Keep your right hand here. After standing the right side of the patient in supine position, you are keeping the right hand such that this part now, wrist part should be in the left parasternal region of the patient, and this part, the base of this hand, should be used to palpate thrills. Okay, and this part, meaning fingertips, is used to palpate the apical impulse. So actually different clinical methods are there. First what they say is, first palpate the patient like this. Okay. Then what you should do is, you should localize this apical impulse by using a finger, an index finger. This is localization of apical impulse. Ishan and Neja, see, normal apical impulses, this is the mid-clavicular line. If you calculate the mid-clavicular line, it will be 1 centimeter lateral to mid-clavicular line. 1 centimeter. Okay, but here what has happened? Sorry, 1 centimeter medial to mid-clavicular line. Okay, so here what has happened in our discussion? It was 1 centimeter lateral in the 5th intercostal space. Normal also 5th intercostal space. So what does that indicate? See this thing for palpation of apical impulse? Yeah. So what has happened here is nothing but right ventricular hypertrophy is happening. Okay. Right ventricular hypertrophy is happening and pushing the apex to lateral side. See here. Yes. We will deal with all apical impulse at one stretch now. Okay. Yes. So what happens here is, first normal apical. What is apical impulse says? It is the downward and outward palpable area of the precordium. Okay, it is a downward and outward area of the precordium which can be palpated by a palpating finger. Okay, that is due to it is actually felt in the early part of systole. Okay. Yes, excellent. Good, Bhuvika. See, location of apical impulse. Where it is normally located, we saw it is 5th intercostal space, 1 centimeter medial to mid-clavicular line. Okay. Next is for tapping, seen in 5th intercostal space. I have told this is normal individuals. Size is actually less than 3 centimeter in diameter, or you can remember like one this 1 rupee coin, like that, one coin. That is the size of apical impulse. Okay, and then Number of intercostal space, only one intercostal space will be covered in apical impulse. And how much percent of systole will be, how much percent of systole will the heart will touch the precordium? It is less than 1/3 of systole. This is a normal apical impulse. Okay. So what happens in tapping apical impulse? It is also seen in fifth intercostal space, but it is usually lateral to midclavicular line, because what happens is this right ventricular hypertrophy, it pushes the heart to the left side. Okay, it is pushing the left ventricle further more to the left side, leading to lateral to midclavicular line. It is seen in mitral stenosis. Size, it is same as normal. The number of intercostal space, only one intercostal space. How much it is occupied? Same thing, less than 1%. Everything is normal, only it is shifted to lateral, and you can feel it as a gentle tap. Okay, you can feel it as a gentle tap. That is apical impulse in MS. Now I want you guys to answer in which conditions you will see hyperdynamic apical impulse. What is the condition? See, in mitral stenosis, as we know, S1 will be loud. People say that only this loud S1 is felt by the palpating finger as tapping impulse. Excellent, Ishan and Nita, it is large high cardiac output states. Good, hyperdynamics. Then, any valvular disorders causing hyperdynamic state? Excellent, you told one condition, it is high cardiac output state. Is any valvular heart disease causing hyperdynamic apical impulse? Excellent, AR. Good. AR, MR, what happens is volume overload is happening and the left ventricle undergoes left ventricular dilatation. So dilated left ventricle, it occupies more than one intercostal space. Okay, more than one intercostal space. And what will be the power of contraction? Will it contract more or will it contract less? Power of contraction will be very less. So it will be less than 1/3 of systole. Or you can say less than 1/3 to 1/2, 50% in systole. Okay. So hyperdynamic state location is what happened to the apical impulse? It is shifted down and out. It is shifted down and out like sixth intercostal space, like that, and it's lateral to midclavicular line. But more period, more contraction. No, it is like aortic regurgitation, mitral regurgitation patients will start undergoing left ventricular dilatation, means the left ventricle is undergoing failure. So at that point of time, that left ventricle can't contract that much vigorously. Okay, that thing. Then it is seen in aortic regurgitation, mitral regurgitation, and high cardiac output states like hyperthyroidism, anemia, all such conditions. Then size will be more than one intercostal space. Okay, and size will be definitely increased than normal. It is diffuse, they will say. Okay, it is felt everywhere, they will say. And percent of systole will be like 1/3 to 1/2 of systole. It will be there. Okay. At the same time, if you see heaving apex impulse, what is this? Any obstruction like aortic stenosis or HOCM, any obstruction in the outflow tract will cause left ventricular hypertrophy. Now hypertrophy is happening. Now what will happen? See, Since the aortic valve is stenosed much, the left ventricle contracts so much to open the aortic valve. Okay, it contracts continuously and forcefully. So it is a strong contraction which is present more than half of systole, and since it is hypertrophied, it is also more than one intercostal space. So more than half of systole, yes, more than one intercostal space. It is, they will say it as sustained, meaning it is contracting continuously. Then it is seen in pressure overload conditions like aortic stenosis, HOCM, even in hypertension, systemic hypertension, all these can happen. Okay. Here is it is shifted. Here is also it is shifted down and out. So only difference to make between hyperdynamic and heaving is this thing, duration of systole. So only it's better to palpate the apical impulse as well as you should palpate the carotids simultaneously. If you palpate carotids, like in complete systole, if you are feeling the apical impulse, then it is heaving or sustained. If you are just feeling for some time, like less than half, 50% of systole, then you can term it as hyperdynamic. Because both represent same conditions, same more than one intercostal space. Okay, you should be remembering. If you didn't got this, just put up a thumbs up smiley if you got this. Very important in differentiating the valvular disorders, apical impulse. Okay, and if it is absent apical impulse, many causes are there. One of an important cause is C. If the apex is behind the rib, then it is an absent apical impulse. Okay, if it is behind the rib or obese persons, emphysema, what happens? The hyperinflated lungs will cover the heart so that the apex won't be felt by the palpating finger. So all these are causes of absent apical impulse. Everyone got this? Yes. Now we will be dealing with this parasternal heave. How to appreciate the parasternal heave here? See, you should palpate and keep your base of your hand at the left parasternal area. Okay, at that time, if you feel if it is lifting it, okay, then you can term it as parasternal heave. Actually, it can be appreciated by keeping a piece of paper. Okay, a piece of paper in the left parasternal area, it will move up and down. That is mild parasternal heaves. And if you apply pressure, then it will settle down. It won't be seen. Okay. Next is this is the method to produce appreciate parasternal heave. We will grade parasternal heave now. See, grade 1, 2, and 3. If it is less than 1/3 of systole and it is obliterated by only mild pressure, then it is grade 1 parasternal heave. It is seen even in normal children. Children may it is seen. And at the same time, very thin people, thin chest. Also, it is normal phenomenon. No need to worry. But if it is due to why it is produced, why is parasternal heave produced? What is the cause of parasternal heave? Two causes I want. One will be, and the other will be this. Okay, see here. Yes. So why was parasternal heave formed? Left axis deviation. Okay, I'll see. So what happens here is, see, either if right ventricle undergoes hypertrophy, this you can feel it as, this is the sternum, this is the ribs. Okay, so if it is undergoes hypertrophy, you can feel it as parasternal heave. Okay, or else if left atrium undergoes dilatation, right ventricle is normal, left atrium undergoes dilatation, what will happen? Left atrium is exactly posterior to the right ventricle. So left atrium undergoes dilatation, it will push the right ventricle towards the parasternal area. Okay, so what does that indicate? Even if right ventricle is normal also, parasternal heave might be there because of left atrial dilatation. Got it? Everyone got this concept? Shouldn't remember like everything is RVH. It can be due to LA dilation also, which happens in mitral stenosis, mitral regurgitations. Okay, so grade 2 and grade 3. This can be obliterated with moderate pressure. It can never be obliterated. Grade 3. Okay, so causes will be all causes of RVH and all causes of LAD. Left atrium will be dilated in mitral stenosis, mitral regurgitation, and right ventricle will be hypertrophied in pulmonary stenosis or pulmonary hypertension due to any cause, or due to tricuspid regurgitations, also cause right ventricle to work more. Okay, all these causes can cause. These causes, if they get more severe, then it will result in grade 3 parasternal heave. At the same time, this also more severe. If MS and MR becomes more severe, it itself will cause pulmonary hypertension and RBH. Okay, everyone got this parasternal heave concept? Okay. Yes, and rhythm, we were speaking pulse rate rhythm character में irregular rhythm is there. That too, if it is irregularly irregular, then we call it as atrial fibrillation. If it is regularly irregular, then it might be due to some PVCs, premature ventricular complexes. Okay. Yes. Then what conditions can cause radioradial and radiofemoral delay? See, there is a narrowing of aorta post giving all the major vessels. In this condition, upper limb artery, upper limb pulse will be felt lot more early, and it takes more late to feel the lower limb artery, or it is feebly felt. What is this condition? Where narrowing of the aorta post giving all the main branches, all the three main trunks. Condition is known as excellent coarctation of aorta. This will have radiofemoral delay. And here also you should remember, like, because of these conditions only, we should check the BP in upper limb as well as lower limbs. Okay, this will be delay. Excellent, Bhuvika. Okay, radial delay. Where will be radial delay present? See, some kind of cervical rib is there compressing one of the subclavian artery. Then it can cause radial delay. Or if you see, we were thinking of embolic phenomena in mitral stenosis. If embolus, one of the embolus blocks one of the brachial radial artery, then it can also cause radial delay. So any emboli or cervical rib, subclavian stenosis, Takayasu's arthritis, all these are the causes you should remember. Okay. Yes. Yes, we have discussed everything. Last part is, so see here, what is happening here? Character is tapping, which confirms MS. It is lateral to midclavicular line, left intercostal space. It's just pushed there. It is occupying only one intercostal space. Then it is tapping. Diastolic thrill is present, so it also confirms MS. Parasternal heave, not oblique treble. What is the grade then now? Can someone say? Heave is there, not oblique treble. What is the grade? Grading of parasternal heave. Excellent. Severe one, which is grade 3. Okay, good. Then pulsations were seen. Okay. Next, we are going to see auscultation, the last topic. How to auscultate in MS? See, this point should be included in case of description of a murmur. Excellent. Good. Ishan, Aishwarya Verma. Good. Yes. So thrill and murmur, both I will say continuously. See, what happens in MS is about the murmur. What happens in MS? See, first thing is for S1 to be loud, own tachyarthrosis affect the entire aortic arch and decreases pulse bilaterally in upper lip. Yes, Bhuvika, you are right. Actually, tachyarthrosis arteritis, as it affects aortic arch, that blood vessel effect won't be there, and we call it as pulseless disease because of this concept only. But in tachyarthrosis arteritis, if you see specifically, most common vessels to be involved in tachyarthrosis arteritis will be left subclavian artery. If it happens, if it affects only the left subclavian artery, in such cases you can find this radioradial delay. We got it? Yeah. Now we will be seeing the auscultatory finding of MS. So, first what happens is, this mitral stenosis is going on. See, when S1 will be loud, just just remember this concept. Okay, if you smash a door, it will produce a loud sound. When will it produce loud sound? Either the person who smashes this door should have great power. First thing. Next thing, the door should be opened completely and then shut, so that it will be a smashing sound will be there. Okay, these two components are needed so that uh, door will be shut with great speed and sound will be happening. Okay, here what happens here is, see here, left atrial pressure is increased here. Okay, because of mitral stenosis, left atrium is contracting in stenosed valve, so left atrial pressure will be increased. So this increased pressure will make the valves, what it will make? It will make the valve wide open. With the increased LA pressure, valves will be wide open. Okay, and now left ventricle is functioning normally or not in MS. Just remember this concept. Left ventricle will be perfectly normal in MS. The failure happens with respect to left atrium. So they say it as left atrial failure and never ever left ventricular failure. So only I'm saying, if PND is there, you should think like it is due to left-sided failure only. It is not left ventricular failure always. Since in MS it is left atrial failure. Since left ventricle is normal, this produces a normal force of contraction. Now the door is widely open and left ventricle shuts down harshly. So that contributes to what S1? Loud S1. Got this concept? Can I move to the next concept, opening snap? Just send me a thumbs up. Okay. Next is, see, this is a normal left atrium and normal mitral valve. What happens is, when during diastole, what happens? The blood from the left atrium will start to empty in the left ventricle. Okay. But in case of mitral stenosis, left atrium will be dilated, and what happens is unstenosed. Okay. What happens is, in this part, this valve starts to bend like this. Okay, it starts to bow like this when pressure starts to increase and goes. Blood starts to pump from left atrium to left ventricle. The valve starts to bow like this. So that, and this narrow valve, blood starts to leak. This produces this opening snap. Opening of a valve, when it produces sound, it is opening snap. Just remember this, if opening snap is there, it is always MS, 100% MS. Okay, although tricuspid stenosis might be there, but in our practical point of view, if you are able to hear an opening snap, then it's definitely MS. Okay, so this you should know. As severity of MS starts to happen, what will happen to this bowing? It will bow so fast because this valve can't resist the pressure, increased pressure. It starts to bow so fast. So my question is here. This is S1, which became loud in mitral stenosis, and in diastole, this S1, then systole, then S2. Then what happened? Diastole happened. In diastole, after some time, when the valve starts to bow, it produces this opening snap. Okay. After this narrowed valve, blood starts to pour in, which is a mid-diastolic murmur. Okay, it is a crescendo decrescendo murmur, meaning crescendo meaning increasing, and it starts to decrease when the complete blood is empty from left atrium to left ventricle. Next, what happens? Last part of diastole is contributed by what? Contributed by what action is last part of diastole? Atrium is emptying passively in the first 1/3 of systole. The last, sorry, 2/3 of systole, diastole. Last 1/3 of diastole, what will the atrium do? Atrium will atrial systole happens. Atrium contracts vigorously. Okay, if it contracts vigorously, that will also produce a murmur. This murmur is called pre-systolic accentuation, meaning this is systole. Before systole, murmur is accentuated again because of this atrial contraction. Okay. Yes, good. Bhuvika, Ichananaja. So, if atrium is not contracting, as in atrial fibrillation or atrial failure, which can also happen in MS, no pre-systolic accentuation will be there. Okay, got it? This thing. Then one more question for you people is, see, if the opening snap comes immediately after S2, what does that indicate? Whether it's severe MS or mild MS. If it comes instantly after S2 and mid-diastolic murmur starts. Excellent. Ishan, it is poor prognosis because it indicates S. It is severe MS. Good, Aishwarya, Ishan. So it's nothing but, see here, it's nothing but this mitral valve can't resist the increased pressure and it bows down so quickly. So only they say the duration between S2 and OS interval is inversely proportional to severity of MS. Meaning, if these are widely distant, then MS is mild MS. If it is close to each other, then MS is severe MS. Got it? These are the components you should remember. So diastolic murmur, na, if this murmur is felt by the base of the hand, like this part, head of the metacarpals, that is known as thrill, diastolic thrill. If thrill is associated with murmur, then we call it as grade 4 murmur. Okay, Ishan got your diastolic thrill. This is in short with respect to auscultation of MS in apical area. Now I want to just ask you some 2-3 questions. See, what if you are palpating this thing, auscultating pulmonary area, you are finding ejection systolic murmur in the pulmonary area. Why does this happen? Why is ejection systolic murmur heard? Because, see here, as I was telling, in right ventricle, what was happening? Excellent. Pulmonary arterial hypertension. Right ventricle, what was happening? Pulmonary artery was getting stiffened and pulmonary arterial hypertension was going on. Okay. So, since this artery is narrowed, through this narrowed artery, blood starts to flow. This produces a systolic murmur. When it will be produced? Only if blood starts to ejected into the pulmonary artery. So it is an ejection systolic murmur heard in pulmonary area. Everyone got it? Okay, this you should know. And it will be a loud P2. Second half. Okay. Yes. So next is, why is there end inspiratory crepitations heard in basal areas? What is the reason? The patient has minimal amount of pulmonary edema is there. So only he is having end inspiratory crepitations. Okay, that's it. We have come to the end. So how to diagnose? How to write a diagnosis at the end? How to write? Whether it's acquired or congenital. Excellent. We got is cardiogenic pulmonary edema. Good. Well, how to write the diagnosis? What is it? Acquired or congenital? It is acquired. Is it valvular, ischemic, hypertension, myocardial? What kind of heart disease is there? It is valvular. What valve is affected? Mitral valve. What kind of mitral valve affected? Stenosis or regurgitation? Stenosis. And what is the etiology? Rheumatic fever, rheumatic heart disease. Atrial fibrillation is there or not? Yes, it is there. And since the pulse was irregularly irregular, then pulmonary hypertension is there or not? It is there because we saw ejection systolic murmur, we saw loud P2, and we saw parasternal heave and epigastric pulsations. All these are suggestive of right ventricular hypertrophy with loud P2 and all suggestive of pulmonary hypertension. Then features of failure. What failure was there? Left ventricular failure, right ventricular failure, biventricular failure. I want you to answer this question. Our patient had what kind of failure? Left, right, biventricular failure. Did he have any peak edema, ascites, abdominal distension, abdominal pain, neck distensions? No. So right ventricular failure was not there. Left ventricular failure was, yes, it was there with ENT and all, and class was class 3. So write it as left ventricular failure, which is class 3 NYHA. Then features of endocarditis? No. Rheumatic fever activity? Now the patient is inactive. Sorry, inhalation and it is left-sided heart failure. You can say. You can say it as left atrial failure. Excellent. Good. Left atrial failure. Okay. Yeah. Left atrial failure with class 3 NHA. So this is the complete diagnosis of your cardiovascular case. Left-sided, which is left atrial failure. Because since you are saying it as MS, you can tell it as atrial failure. Yes, so this is the complete diagnosis of your patient. Okay. Yes, thank you, Ishan. So these are the your images. Only one image you can see. This is the heart. See what happens to the heart in mitral stenosis. Normal, this it will help you. See here. This is the heart. Left heart border will be formed with the right atrium, right heart border, and right ventricle, something, and left ventricle will be forming the apex here. Okay, so here it is the bronchi. Yes, left atrium is getting enlarged here. So what happens to the carina? See, going here, it causes splaying of carina. Okay, widening of carina, they will say. This is seen with respect to mitral stenosis. Next, what happens to the left heart border? It is getting straightening of left heart border because of the enlarging left atrium. And if you see, left atrium will enlarge here also, and it will enlarge here also. Like see here, you see closely, you can see two borders. Okay, this they will say it as double cardiac borders. Okay, all are these are findings of mitral stenosis in chest X-ray. Okay, and if the patient is on failure, then upper lobe pulmonary veins will be prominent. Upper lobe and edema will be what kind of distribution? Bat wing distribution. Upper lobe veins predominance indicates pulmonary edema plus failure features in chest X-ray. Okay. Yes, that's all. So treatment is medically will manage the congestive cardiac failure, atrial fibrillation, infected endocarditis if it is there, and treatment of choice if they ask it is valvuloplasty only. They will inject a balloon and that balloon will go and dilate that stenosed mitral valve. Okay, but here you should ensure whether the left atrium is free of clots. Okay, because if you inject a balloon inside and if you are dilating with that balloon, at that point of time, if a left atrium has clots that might be dislodged, it can cause systemic embolism by your treatment itself. So that should not be there. So first, check whether the patient is free of clots by doing echocardiography. Then you can go for mitral valvuloplasty. And there is valvotomy or commissurotomy, they will say. Since I was telling you, first commissure starts to fuse in MS, we will cut down those fused commissures. This is commissurotomy or valvotomy. Okay, this is the treatment of choice with respect to MS in terms of pregnancy. MS in pregnancy, we are not going to take much risk. Just going and cutting in the commissures, and we will come back. Okay, this MS with pregnancy with symptoms. Yes, that's all. Valve replacement also we'll consider next stage. Okay. Thank you. Thanks a lot for listening to it. Uh, if it goes out well, we will think of next one more case presentation. Did you guys like this? Any changes to be made? Any changes to be made? Thank you, Bhuvika, Ishan, Aneja, Aishwarya. Did you people learn something new today? Yeah, I'll upload the complete PDF now in the groups now. Next class, if it goes well, we will discuss of a next case presentation on CVS. We'll discuss with some iotic valve problems, and we will see how to see those peripheral signs of aortic regurgitation, how to feel those peripheral signs. We will see all those video sessions in the next class. Okay. Yeah. Any improvements do you want? Okay. If you felt any improvement to be done or any things you want in extra, like any case specifically you want or any topics you specifically want, you can mention in our WhatsApp groups and Telegram groups. Okay. MST Medicine Sketchified. We'll plan doing videos or sessions on that. Okay. Thank you. Bye bye.